Dr. Naresh is practicing as a physician and diabetologist in Manchester. And I remember his one quote that medication should be always after the education. So he's a very good educator. Over to you, Naresh, sir, for your talk. Thank you.
Thank you very much. I'll try and share my screen. So thank you, Ashish, for a fabulous presentation. Always good to hear a cardiologist speak before me, in the sense that, as you said, in the UK, there's a lot more cardiologists taken on board about diabetes now, and that is fantastic. And as you said, we also are arguing the toss whether SGLT2s are cardiology drugs or diabetes drugs, but it's good to know that we're all fighting for the same reason anyway. So I want to just take a perspective from primary care, and I'm lucky enough to sit in secondary care as well. So I can see what's happening on both sides of the coin in a sense. And so I just thought we'll just do a little bit of, I'm not going to go straight into the trials, etc., because I do feel that we would have touched into a lot of it during this conference. So these are my disclosures. So we know, we talked about, again, we must have heard about this a lot of times now. Diabetes is a growing global epidemic. 1 in 11 people have diabetes, and it's going to increase year upon year. And none of us, especially in diabetes world, or now even in the cardiology world, are not going to be out of business. 80% of diabetes burden is the low and middle income countries, and 30 to 80% have undiagnosed diabetes. But we also know about how to treat diabetes. We know that once we start treating diabetes, we want to try and prevent micro and macrovascular complications. And again, this is teaching you to suck eggs with regards to these. And one of the things we were focusing today on was the thing around the 33% increased risk of hospitalization for heart failure. And diabetes is just more than hyperglycemia. I think, like Ashish was saying previously, when the diabetes world, a lot of the diabetes specialist nurses, etc., were focused on hyperglycemia as the main aspect of management of diabetes. But now we know there are huge other implications around it. It needs to be a little bit more holistic. And I think a lot of the holistic care generally tends to happen in primary care, dare I say, and in secondary care sometimes, although I am sitting in secondary care at the moment, I also feel a lot of us are still glycemic focused until the recent cardiovascular outcome trials. Again, this data is available for everybody to see that the importance of glycemia. So one thing we should not forget, yes, glycemia is important because it does reduce all these complications. But patients with type 2 diabetes remain at increased CV risk. And again, we can see in the UK with regards to improvements in the use of statins, ACE inhibitors, etc., we have reduced the morbidity associated with diabetes, but death from diabetes associated with cardiovascular risk still continues to remain at a high level. And again, Ashish touched upon this about optimization of therapies. I mean, it does not happen just in cardiology, but also in diabetes as well. About this is work done by Kamlesh, etc. as well, which shows actually we take such a long time for adding additional therapy. In heart failure, they get discharged into primary care. We ask them to optimize, up-titrate therapies, and that generally does not tend to happen, which is a sad thing because that actually promoting or increases the mortality associated with heart failure. And time to additional agent, again, this is, again, like I said, it is work done by Kamlesh. It just shows mean A1C intensification was 8.7%. And by the time we get to using insulin, it generally tends to be about 6 years, which seems like a phenomenally long time for a person with diabetes, with all the added problems associated with diabetes and the microvascular and microvascular complications. We're talking about heart failures per se. Heart failure is one of the first complications, the cardiac complications, type 2 diabetes. It's very frequent. Again, 68% in one study had evidence of LV dysfunction 5 years after their type 2 diabetes diagnosis. It shows that these people are the ones who have not had a previous ischemic event, still presenting with some evidence of LV dysfunction. And it's almost forgotten. Again, if you look, 28% of patients with type 2 diabetes population had undiagnosed heart failure. And then it's fatal. Again, Ashish touched on this. concomitant diabetes doubles the risk of heart failure in people with risk of death in people with chronic heart failure. Besides risk factors for development of heart failure, type 2 diabetes also increases the risk of hospitalization for heart failure. We do know that repeated hospitalizations for heart failure, again, increases your mortality associated with the heart failure. So just reiterating the point, that heart failure hospitalization associated with very poor prognosis. Then again, we touched upon this before. There's a heart failure and diabetes interaction, a two-way pathophysiological link. I won't go into this because Ashish has touched on this about the different mechanisms that are reported to be involved in development of heart failure associated with diabetes. And heart failure has wide clinical implications, including the potential for kidney damage. I think one thing we're trying to understand nowadays is, okay, there is a link between the heart, the kidney, and then how is it that one thing leads to the other and worsens one another? And that's why I think not just heart failure combined clinics, we're now having what are these, we nationally call Care-Me clinics. Currently we're developing, the guidance has already come out on how to run a holistic approach to patients with diabetes by running what are called Care-Me clinics. So heart failure increases the risk of kidney function decline and adverse kidney outcomes. So on the left, you can see heart failure is associated with more rapid decline in EGFR. On the blue bar is the person with heart failure showing at least 22% rapid decline in EGFR compared with those without heart failure. And heart failure is also associated with significantly higher risk of incident chronic kidney disease and mortality. So you can see there is a link between heart failure and kidney disease. So it's not just enough talking about heart failure, we need to link that with the kidney and the metabolic consequences of diabetes. Declining and EGFR and worsening albuminuria increase the risk of developing heart failure. This is also considered individual risk factors for developing heart failure and increasing mortality and morbidity. And what we also need not forget is not only is heart failure increasing in prevalence, diabetes is increasing in prevalence, but diabetes and CKD is also increasing in prevalence. Like we said before, there are 422 million adults living with diabetes. 30 to 40% of these patients will develop CKD. And the number of deaths associated with CKD, as you can see on the right, is rising exponentially. And it is the leading cause of end-stage kidney disease, and prevalence is increasing. So preventing diabetic kidney disease or reducing diabetic kidney disease progression could reduce CV events in type 2 diabetes. So what I'm trying to do here is just saying it's not just about heart failure, but it's not just about the kidney, but it's a whole system approach that we need to be having, which is what, again, Ashish talked about, like he said, they had this multimodal clinic with the patient at the center. And that data was published about 10 years ago, and we still haven't properly established these clinics. And right now we want to bring in a nephrologist into the whole team as well. He did have a nephrologist on the slide as well, but I think now the nephrologist is going to be more acutely involved, especially with the therapies that we are talking about nowadays. So if you look at it, compared with diabetic patients with no kidney disease, people with diabetes and stage 3 kidney disease have 3 times the risk of congestive heart failure, 85% higher risk of myocardial infarction, and 65% higher risk of stroke. Therefore, focusing on detection of DKD and preventing or slowing this progression could substantially reduce rates of cardiovascular and non-CV events. So unsurprisingly, cardiorenal disease associated with mortality risk in type 2 diabetes. So heart failure, CKD, you can see the hazard ratios are high, and similarly with regards to all-cause death as well. Despite this, there's a high prevalence of both undiagnosed heart failure and CKD in type 2 diabetes. I think one of the things we are trying to promote here in primary care is for GPs and nurses to have a high index of suspicion with the person that presents to you with symptoms such as shortness of breath, fatigue, leg edema, but no previous history of ischemic heart disease. We're trying to build into the templates of the nurses asking these particular questions. And we're trying to develop that and saying what particular question will direct us to send a person with previously no history for a BNP or an echo. So things like orthopnea, Are they using more pillows than normal, but they have not had any diagnosis of ischemic heart disease or heart failure? So if you look at this, I showed this before, it's 28% of patients who are undiagnosed. And with regards to CKD, not a lot of persons with diabetes know about CKD. And then once you talk to them and say, oh, I've got chronic kidney disease, they suddenly start getting very worried about it. So if you think about it, 96% didn't know they had CKD stage 1 to 2. 82% did not know about that stage 3 kidney disease. So cardiorenal risk develops along a risk continuum, highlighting the importance of early prevention. Again, prevention is the key here now. Now that we got a lot of data talking to us about, okay, when do we introduce certain therapies? Can we introduce it earlier on in the disease cycle to enable better management and reduce cardiovascular outcomes? So you talk about multiple risk factors, which we have to deal with no matter what. And then we talk about disease progression, risk of complication outcomes. Lifestyle modification is something that has to exist throughout the disease cycle. And then you look at medication targeting specific conditions, complications, and outcomes. So this is where prevention works, and there's a therapeutic window. The reason for this is we do know that some of the trials, the cardiovascular outcome trials that have been discussed at this conference and also to be discussed later, some of them focused on people with established cardiovascular disease, and some of them focused more on patients with multiple risk factors. Those are the people that we generally tend to see in primary care. And the people to the right are generally tend to be people who Ashish probably sees. You probably have established cardiovascular disease. So the question is, how can we add life to years and not just years to life? Again, we talked about this multidisciplinary approach. Important to have lifestyle advice and support. You optimize blood pressure, lipids, and CKD. And in the UK, we have what I call the 3 treatment targets. That's the HbA1c, blood pressure, and lipids. And those are mandatory, and I think they are the keystone of management. But now have these additional therapies that are available that will help us look beyond those 3 as well. One thing we advise in the UK, and like Ashish touched upon it, in India, there's a lack of registers. Here we have registers and we have phenomenal data within primary care. We're trying to encourage people to actually audit the people with diabetes and look at people who are possibly high-risk groups and probably bring them in for medication optimization and change of medication if necessary. DPP-4s are commonly used and very widely used and very cheap, and they're probably the 2nd most prescribed drug, or probably 3rd most prescribed drug after metformin and sulfonylureas. But they do not reduce CV events. They can be what you call, they are safe, but do not reduce CV events. Again, Ashish touched on the fact on one of his slides about saxagliptin not being a good drug to use in people with symptoms suggestive of heart failure. Whereas SGLT2s and GLP-1RAs, the effect of major adverse cardiovascular events across all the trials, you can see the benefit. Obviously, Elixir did not show that much, but every other trial, Leader, Sustain, Excel, Pioneer, the EMPA-REG, Canvas program, Declar-TIMI, all of them showed cardiovascular benefits. GLP-1RAs demonstrated neutral effects on the risk of hospitalization for heart failure in patients with established cardiovascular disease. But SGLT2 inhibitors can prevent hospitalization for heart failure in patients with ASCVD at baseline. All these trials that we looked at, EMPA-REG, Canvas, Declar-TIMI, all showed that. Obviously, the patient populations were different in each of these, especially if you look at Canvas and Declar, they had people with multiple risk factors, a higher proportion compared to EMPA-REG, etc. So when people ask you, okay, which SGLT2 you use, I think it's difficult to just say, use this one, use that one. But I think I would focus on what the trials showed, what the patient population was. And a lot of people would argue whether this is a class effect, but I'll leave that for a discussion for another day. So again, available evidence suggests benefits are modified by kidney function. Whatever the EGFR, there seems to be some benefit, because we do know below 60 of EGFR 60, the higher the glycemic effect or hypoglycemic effects of SGLT2 inhibitors is much reduced. So it's purely for that they had an EGFR of 60. It was not for any safety reasons, it's more for efficacy. But we do know that below 60, the effects for heart failure and kidney disease were present. So that's why the licenses are changing currently. Again, I'm not going to go through this, but SGLT2 inhibition may improve hemodynamic parameters. Patients with type 2 diabetes potentially leading to cardiorenal protection. Various mechanisms have been put forward for how SGLT2 inhibitors might be protective. And they talked about diuretic effect, the effect on the arterial walls, effect on the heart itself. So there are various things, and it's still being investigated. We're not completely sure. So how has it affected the guidelines? I mean, there have been huge changes in the diabetes guidelines across the world. Sadly, NICE is still coming up to speed with that, and they're currently undergoing change. But at the moment, if anybody was managing person with diabetes, would tend to use either the ADA, EASD guidelines. And this actually, what is happening, this actually takes into account what is happening within the cardiovascular outcome trials. So what do we do? I mean, most guidelines tend to be very cumbersome and huge. So what we did in Manchester was try to develop what's called the Manchester Cardiometabolic Pathway. Excuse me. And we tried to distill the guidelines into one page and try to make it easy for people managing diabetes in primary care to be able to decide what the next best therapy is. And all this was evidence-based. And the pathways generally tend to be dynamic. So because as the evidence is changing, we need to be changing the pathway as well. Guidelines, especially in the UK, will take much longer to change. So we go through various bits of how to manage with regards to monotherapy, dual therapy, presence or absence of ASCVD, etc. Again, triple therapy, and then intensive therapy over insulin. So it takes you through various stages of management. So I've just put up a case here, just purely from the fact that I'm not going to go through an elaborate discussion about it, but this is kind of a typical person you might see in our clinics who presents with raised HbA1c and lipids are satisfactory, but he has a diagnosis with heart failure 6 months ago, and the question was always what next after metformin. And this is where our guidelines come into focus and say, well, actually, if you have somebody with this sort of risk factor and heart failure CKD problem predominates, think about using therapies such as the SGLT2s, which have cardiovascular outcome benefit. Again, if you meet the same person, John, but this time with a CKD progression, we try and advise about diabetes kidney disease management, which generally talk about A, B, C, D, which is ACE inhibitors, blood pressure targeting, cardiovascular risk reduction, and diabetes management. Again, the guidelines suggest that if CKD predominates, you focus on the type of therapy that would invariably tends to be an SGLT2. And especially with the data that's come out now with regard to canagliflozin, and then we are awaiting data from DAPA, CKD, etc. So this has been a game changer for us with regards to using canagliflozin, and it gives you proper guidance on when to initiate canagliflozin. And it's taken away the barrier of EGFR of 60. So what do we do with intercurrent illness? This is another thing that we're promoting heavily, especially during the COVID period, trying to, especially people who are on SGLT2s, trying to show them the importance of remembering sick day rules. And we use this acronym, which is called SADMAN, which is SGLT2, ACE inhibitors, diuretics, metformin, ARB, and NSAIDs. These are the therapies that you need to look at if you are unwell. There are numerous resources that have been available for people to try and manage diabetes in primary care. And we've got this available at GP Notebook and gives you a step-by-step guidance about which SGLT2 use, when to stop, a red, amber, green guide for usage of SGLT2s. And so it makes it easier. The reason for all this is to try and promote earlier initiation of therapies, which we know now have huge benefits for persons with diabetes. And also, we're talking about people with heart failure and no diabetes nowadays. Again, GLP receptor 1 guidance. So when I die, I want my grave to have free Wi-Fi so people can visit it more often. So in summary, type 2 diabetes is complicated by multiple interconnected cardiorenal metabolic conditions, and type 2 diabetes, CKD, and heart failure, especially intertwined, is associated with an increased risk of heart failure and end-stage kidney disease, both of which result in poor prognosis and increased risk of mortality. There's a bidirectional risk relationship between heart failure and CKD, with onset of one associated with increase of onset or progression of the other. And cardiorenal risk develops across a continuum, highlighting the need for early intervention to prevent disease onset and progression.